Hello, dear AeHIN members and my dear colleagues from Bangladesh. Good evening, everyone. So today I will briefly share the status of the Standards and Interoperability Lab in Bangladesh. Although the lab has not yet been formally established, important foundational work has already been completed in standards terminology and interoperability preparation. So my presentation will be a short presentation, not too long. So why the interoperability labs are important? Most countries, including Bangladesh, already have many digital health systems, but these systems often work in silos. Data cannot be exchanged efficiently, and policies remain in narrative form rather than in computational formats. There is also a capacity gap in implementing standards like fire and terminology systems. This is where standards and interoperability lab becomes important. It acts as a national coordination platform and solves these issues. So what is standard and interoperability lab? It is essentially a regulatory sandbox where real-world digital health problems are solved collectively and collaboratively. It helps convert narrative policies into computational standards like fire profiles and implementation guides. The lab supports training, tool development, testing, and collaboration. It brings together government, developers, private sector, and the partners into a single working environment. So the current status of SIL in Bangladesh. Currently, the Standards and Interoperability Lab has not yet been formally established in Bangladesh. However, there is strong national focus on interoperability under DGHS. We are actively working on standards, terminology, and preparing the interoperability infrastructure. Rather than starting with a physical lab, we are following a phased approach, building the foundation first. In the phase one of the foundational work, already we have published the first draft version of the core fire implementation guide. We adopted Open Concept Lab as the terminology service and formulated the terminologies into OCL. And currently, we are integrating the implementation guide in fire OCL terminology. So we aligned citizen core data structure with national standards from the cabinet and adopted the geocodes from the Bangladesh Bureau of Statistics for consistent geographic information captured through the FIRE IG. In terminology, we are using ICD-11 for diagnosis and findings, and we are using DGDA drug list mapped with ICD-11 medicaments. So DGDA is the drug formulation authority in Bangladesh. And we adopted LOINC for laboratory results. Some areas like examinations and radiology require broader stakeholder consultation. So we are following a phased approach, moving forward with what is ready and while continuing work on the rest in parallel. In the next phase, we are focusing on infrastructure. We are planning to deploy HappyFire server, which will serve as the interoperability layer. This will allow us to create a testing environment and support real system integration and data exchange between different health systems. And in the third phase, we plan to formally establish a standards and interoperability lab under DGHS. This will include a dedicated team with expertise in interoperability, terminology, and system implementation. The lab will support training, tool development, testing, and the coordination among stakeholders. So instead of starting with a physical lab, Bangladesh prioritized building the core foundation first, standards, terminology, and architecture. Now we are moving toward infrastructure and institutionalization. This approach helps ensure sustainability and real-world implementation rather than creating a lab without foundational and functional outputs. So from our experience so far, A few key lessons have emerged. First, standards must be established before building systems. Second, terminology is a critical component of interoperability. And third, translating policy into computable formats is essential. We also learned that while standards and terminologies can be developed in many technically correct ways, not all approaches are implementer friendly. In Bangladesh, we are prioritizing an implementer friendly approach as many stakeholders are still new to these concepts and may have some hesitation. A phased approach helps reduce risk and governance plays a key role alongside technology. So going forward, our focus is to complete the alignment between the fire implementation guide and the terminology system. We will then deploy the Happy Fire server as the interoperability layer. We will then select a priority use case for real-world implementation, and we will move toward formal establishment of the SIL under DGHS, along with stronger stakeholder engagement. So that's all from my side. If you have any questions, I'm ready to share the answers. Thank you.
Thank you, Dr. Islam. Wonderful work that you're doing right now in Bangladesh. Um, do you have any particular priority use cases that you've selected to focus on? I know you're working on the Bangladesh core, which is very important. But what is that particular use case? Is it maternal care, immunization, or cancer, or what is that first use case against which you can now test the Bangladesh core?
So we have optimized the Bangladesh core for the general inpatient department information. So mainly the
Mhm.
discharge summary. It is our current priority to start with. And
The discharge summary.
along with the discharge summary, we are also thinking about capturing the MCCOD data from our health facility.
Yeah, the mortality
Yeah,
cause of death. Yeah,
cause of death.
MCCOD.
Yeah,
Right, right. That's good. That's
medical
good.
certification of cause of death.
Medical certification, cause of death. Have you already shifted to ICD 11 or are you still at ICD 10?
So we are actually using ICD-10, but we have been piloting ICD-11 for last 2 years in our six facilities, and recently we have expanded the piloting in another 2 hospitals. So currently, 8 hospitals are using ICD-11 along with ICD-10 for routine health information.
Do you have team members already with the lab who are I mean the people who are there for terminology and for interoperability?
Yeah, so we have currently 13 members in the terminology committee who are actually working on the interoperability.
13 in terminology or also
Yeah.
interoperability.
So it is a merged members. So
Mm-hmm.
there are some overlapping members. And
Yes, yes.
mostly the 30 members are working on the terminology as well as the interoperability.
And in Bangladesh, how many EMRs are there right now that are known with the MOH?
So in the public hospitals, we are using the hospital automation system or the EMR, whatever you say, in 100 hospitals among 600 hospitals.
That's homegrown from the Ministry of Health?
Yeah.
Sorry, what do you call that EMR?
Yes, the automation system is basically the EMR. EMR along with the other business processes in the hospital.
Automation system. All right.
Yeah.
Thank you. Maybe if there are any also other questions from the audience, Bangladesh was one of the newest labs that we added into the community of interoperability labs. And we're happy that Dr. Islam agreed to give a presentation on their phased approach, which I think is really very practical because when you're beginning, it's good to be able to address doable bite-sized cases. And they selected the inpatient discharge summary and MCCOD. I think those are very good use cases. Yeah, Jai, go ahead. You can ask your question.
Yeah, thanks, Alvin. Like I had similar questions, like including ICD 11. Riazul, like I was thinking about like how about SNOMED? Like I know Bangladesh was working on shared health record as well. So we have had previously we have had some discussions on that. So I was looking at like AeHIN and SNOMED International have this collaboration, especially on awareness, capacity building, and then support getting the development license. So I've just shared the link also on chat. And then very soon that maybe we will also be able to reach out to countries on this to take their interest and then see like how we could facilitate via the community of interoperability laboratories regarding the development license of SNOMED CT. So I was just pointing the question related to that because we just had clarity regarding ICD, and then of course fire is something that you already mentioned about, but then and then like also you already mentioned about. So but having clarity regarding SNOMED CT will also be helpful probably to for the labs, the community to help Bangladesh. Thank you. Over to you, Razul.
Thank you, Jay. Nationally, we have decided to adopt ICD 11 for coding the um, findings and the diagnosis. And currently, there is no decision for adopting a SNOMED in any use cases right now. But if we decide later, I will definitely let you know. And thanks for the dissemination of this information with us.
Thank you, Riazul. One thing is like SNOMED just recently also expanded their global patient set GPS, SNOMED GPS. So that is also there. And then this developmental license, like for example, it's a long journey probably, and it's also a political decision for countries to make. But then like you have the opportunity to take the development license, pilot test some use cases, and then make an informed choice. So this is possible via this collaboration. So I'm just bringing it to your notice, and then of course, like it's up to the interoperability standards and interoperability team to take a call on this, and then like feel free to approach our team. Thank you.
Yeah, thank you.
Also, we discovered, Dr. Islam, that ICD 11 has different. I'm not an expert in ICD 11, but it has a specific feature called MMS, which is the official reporting framework of the World Health Organization. It's going to be I think the way WHO will be expecting the reports to come in from the countries. And then there's this they call it the shoreline. The shoreline is the demarcation within ICD 11 of all the foundational concepts and terms. And then the shoreline, above the shoreline would be the MMS, because they have linearization and in ICD 11, and there's complementation of SNOMED and ICD 11. ICD 11 being the official reporting framework, and then SNOMED having all of the multi-axial concepts that are very rich for clinical. So ICD 11 for public health reporting, and then SNOMED for clinical control terminology. Thank you, Jai. Any other questions from the other groups? I made an announcement earlier about um, we currently have 11 countries right now that have signed up to be a member of the community of interoperability labs, and Japan and Vietnam are currently work in progress. They're still organizing themselves. But if there are other countries in the call who wish to set their own lab, just feel free to contact me or PT, and we will guide you on the process. Of course, that's why we invited Dr. Islam here, so that he can also share how they're doing it there. So there's no right or wrong answer on how to set up a lab. The best answer is the lab that addresses the needs of your country. And in Bangladesh, Dr. Islam shared that the lab is going to address the use case of inpatient discharge summary and medical certification cause of death. And that's, I mean, that's very important to be able to get a use case and then having the lab helping out the Ministry of Health how to craft the terminology and interoperability APIs along the lines of discharge summary and MCCOD. Uh,
Alvin, I see
yes,
a
Jai.
question from Zakir.
Yes. Jakir, go ahead.
Yeah, hello, Dr. Alvin. Yeah,
Hi.
and very nice presentation, Dr. Riazul Islam. So, I have a question on you already mentioned about the discharge node. So, from which facility you are using this discharge node?
Oh, we are using the discharges from different tiers, like the primary healthcare facilities and the secondary healthcare facilities and the national specialized institutions.
Thank you. And I also agree with Dr. Joy and Dr. Alvin. So, we should consider the Snomet city because beside ICD 11, Loin, so if we consider Snomet city, so it would be more comprehensive. Thank you.
Yeah,
Thank
thank you.
you.
And it is also possible to map the ICD-11 concepts with SNOMED. So
Yeah.
later it will be not a problem if we adopt SNOMED city at any point.
Thank
So
you.
for that purpose, Dr. Jakir, Dr. Islam, we'd like to invite you to browse. Of course, the SNOMED browser is always available
Yes.
from the SNOMED website, but we also have a setup in the Fire Lab. That is a project that supports Fiji and the Philippines. It is a terminology server with SNOMED development and research license built in. So it's there for you to browse around and experiment, and you can start creating value sets. You can start creating value sets in the Fire Lab, and it will show you, you know, all the different aspects and parameters that are inside a fire terminology server that you can leverage with your interoperability lab. Feel free to use it. It's just available. It's online. It's always on. I might hold a session on how to create value sets and also how to call them from electronic medical records or fire forms. Uh, any other questions from the group? I think we had a very rich brief. Maybe Rukshan, we can hear from Rukshan. Rukshan, because we had you as a previous speaker on clinical quality language. Maybe we can take advantage on. Do you have any CQL for medical certification, cause of death, or discharge summaries?
Uh, yes,
Rukshan?
thank you so much, Alvin. Yes, it's good to see so many familiar faces today. And yes, the cause of death and civil registration, vital statistics in general, with our work, we found to be like quite complicated because they overlap not just health, but also sometimes Ministry of Home Affairs, sometimes different ministries, different departments, and it for some reason it's one of the most challenging parts of healthcare, at least that we worked on, because it goes beyond health to administration and different departments, and they have different regulations, and sometimes they don't know these fire or CQL, these terminology standards apart from the ministries of health. So it's very challenging. And that's, I think, one reason for the lack of adaptation for capturing civil registration, cause of death, and all this coding in fire CQL format. But I think people are making progress, but that's one reason, I guess, that slow adaptation for this standards in cause of death and vital statistics in general.
So, Rukshan, I have a quick question related to the discharge summary and cause of death. I think the cause of death is more or less standardized, right? I mean, this comes from WHO, the MCCOD, and then maybe clinical quality language might be and correct me if I'm wrong, a downstream uh, standardization intervention. The upstream is really to is coming up with the profile and the implementation guides, and then the CQL will follow after that, or is there best practice where you do the CQL first before you design your profile and IG? Can you enlighten us on the sequence?
Yes, I think they should go hand in hand in parallel because part of the CQL and the guideline also gets published in the IG, and the CQL, especially the terminology, are intertwined with IG. So I guess it's better to develop it in parallel, or the IG first and the terminology is standardized before getting into CQL, because CQL heavily relies on the data dictionary and for the decision support logic to be calculated. So the terminology has to be standardized first to be used in CQL. So either I would say they go hand in hand in parallel, or first the IG and the data dictionary gets standardized, published, and then it comes down to the CQL coders to code the logic based on the data dictionary.
Okay. Thank you for that, Rukshan. Dr. Islam, if we find 2 or more countries interested in MCCOD, maybe we can create a subgroup with you and 2 other countries on MCCOD. I think that's a very, very common interest right now in several countries. Definitely in the Philippines, we're interested in MCCOD. So maybe Philippines, Bangladesh, and then Roxanne, if you're available and you have time, maybe you can advise us on the upstream, the value set creation, the profiling, and the IG. Maybe we can also invite somebody from WHO, MCCOD team to give us advice on how to move forward with that. And then that might be a regional project. And then Roxanne, when we get to the point of we creating the clinical quality language, I hope that we can count on you to help us out, after we create the regional MCCOD implementation guide. You'll be there to also help us out on the CQL extraction.
Yes,
Is that
Alvin, happy to help as
all right?
always
Thank you, thank
to
you,
the community.
thank you, Doc. Thank you, Dr. Rokshan. Dr. Jakir, your hand is still raised. Do you still have questions?
Sorry, no, it's the previous one. Thank you.
All right. Okay.
Dr. Alvin,
Yes.
sorry, I think we have a question from Miss Fatima.
Yes. But yeah. Go ahead.
Yes,
Cha.
is the SIL in Bangladesh established within MOH? In terms of governance, who is overseeing the lab?
Thank you.
Yes, we are planning to establish a lab under MOA, and the Director General of Health Services will oversee the lab as the principal implementing authority or agency.
So do you have a budget for this, Dr. Islam, or this is all added on to the existing workload of the Silab Bangladesh team?
Well, the establishment will need some hardware setup, and we already have this. And we actually sought help from AeHIN for the technical help, and
Yes.
we look forward to get the help from the community.
Okay. We'll share with you one paper we wrote where it included a budget for the interoperability lab. So I'll share that with you privately. You might want to look at it and then see if you can, like you can change the figures, but more or less, all the components, like the cloud, the software that's needed into the cloud, and then the people and the job description of the people. Of course, you can change it depending on your own needs in Bangladesh, but at least it's a starting point. And I think you will get funding for that. I think when the development partners see that it's a standardization project and it can be very helpful later on in getting quality data from the different programs of the Ministry of Health, even from the private sector. I think you will get the funding for the laboratory. Thank you. Any more questions? Yes, Jai, your hand is raised again.
Yeah, thanks, Lynn. Riazul, I just wanted to bring to the notice one of the previous discussions related to, the AI and then also related to language. So if that has a use case also related to standards and interoperability, if you think that is appropriate, probably you could share. And if there is a clear use case, with what will be the outcome, I think probably that's easier to write it up as for the any seed grant, because I think it all starts with a use case which has relevance to either a donor or a development partner, or maybe even private sector or someone who is willing to actually support. So if that is the case, then I think that could be the starting point, and then there might be opportunities where uh, maybe there are like it could be also a joint application for funds. So there are possibilities, but if that work related to AI, which I think quite some time back that we had discussed, if that has relevance to this, then you can mention. If it is not, then of course we can leave that.
Well, I apologize for the delay. I was supposed to give you the write-up much earlier. As you know, there are many changes in the government, but now the situation has come down and everything is settled. So I will share the write-up with you very soon.
Thank you. Our means if it is of course related to this current discussion we are having related to standards and interoperability, of course you could actually link that up. But if it is not, like, of course we will take it up in a separate way. Thank you.
Thank you, Jai. Thank you. Again, I'd like to repeat, if you want to set up a lab, please just let us know. We'll show you some of the different ways that the other countries have built up their lab. We're here to learn from each other. And then what are the business cases, how to market, how to conduct webinars inside your own country, how to address a use case. Just approach me, Jai, or PT, and then we'll help you out. All right, I think we can give back the rest of the hour to the participants. Of course, I'd like to thank Dr. Yazul Islam for his time and his generosity in sharing with us their story. I hope we can, get you again after 6 months, 1 year, Dr. Islam, and then we can get a chance to learn from where you are at right now. And then, chat, maybe the photo. Can you help us?
Thank you, everyone.
Thank you, everyone. See you at the next COIL webinar. Thank you.
Yeah.
Good night.
Thank
Thank you,
you.
Dr.
Thank you.
Islam. Rukshan, thank you.
Thank you, Alvin. Bye.